Welcome to Medical Specialist Associates Educational Series on Topics in Anesthesiology. I'm Christopher Voss, MD, MS, FCCP, Board Certified in Anesthesiology, Critical Care Medicine, Neurocritical Care Medicine, and Pain Medicine. The 2023 ASA Practice Guidelines for Monitoring and Antagonism of Neuromuscular Blockade provide critical updates on best practices for managing neuromuscular blocking agents during and after anesthesia. The primary goal of these guidelines is to enhance patient safety by reducing the incidence of residual neuromuscular blockade, which is associated with adverse outcomes such as airway obstruction, reintubation, pneumonia, and prolonged post-anesthesia care unit stays. Monitoring of neuromuscular blockade. Neuromuscular blocking agents, both depolarizing, succinylcholine, and non-depolarizing, rocuronium and vecuronium, are commonly used in anesthesia to facilitate intubation and improve surgical conditions. However, residual neuromuscular blockade can lead to serious complications if not properly monitored and antagonized. Clinical assessment alone, such as sustained head lift or grip strength, has been shown to be insufficiently sensitive for detecting residual blockade. This is due to the variability in neuromuscular blocker action and the insensitivity of clinical signs to significant levels of paralysis. Studies have demonstrated that clinical assessments fail to detect residual paralysis in a significant proportion of patients, underscoring the need for quantitative monitoring. Recommendations for monitoring. Quantitative monitoring, specifically using train-of-4 ratios at the adductor pollicis muscle, is strongly recommended over qualitative assessments, visual or tactile train-of-4 fade, due to its higher sensitivity in detecting residual blockade. This method allows for an objective measurement of neuromuscular recovery, ensuring a train-of-4 ratio greater than or equal to 0.9 before extubation. The adductor pollicis muscle is recommended for neuromuscular monitoring, as it provides a reliable indication of overall neuromuscular recovery. Eye muscles, such as the orbicularis oculi, should not be used due to their faster recovery, which may lead to premature extubation decisions. Why use a train-of-4 ratio greater than or equal to 0.9 to ensure adequate neuromuscular recovery? Studies have shown that patients with a train-of-4 ratio less than 0.9 are at increased risk for complications, including upper airway obstruction and aspiration. Quantitative monitoring that confirms a train-of-4 ratio greater than or equal to 0.9 before extubation significantly reduces the incidence of these complications. Antagonism of neuromuscular blockade. The choice of antagonist and the timing of administration depend on the depth of neuromuscular blockade and the specific agent used. Suigammadex is recommended over neostigmine for antagonizing moderate to deep neuromuscular blockade induced by steroidal agents such as rocuronium and vecuronium. Suigammadex binds to these agents directly, reversing their effects more effectively and reducing the incidence of residual blockade. Neostigmine remains a viable option for minimal blockade, TOF ratio 0.4 to less than 0.9, particularly when suigammadex is not available. However, it is less effective for deeper blockades and carries a higher risk of residual paralysis. Dosing and timing considerations. Suigammadex. The recommended dosing is 2 mg per kilogram for train of 4 counts of 2 to 4 and 4 mg per kilogram for deeper blockades. For immediate reversal following a large dose of rocuronium, 16 mg per kilogram may be required. Neostigmine. When used, neostigmine should be administered at a dose of 30 to 50 micrograms per kilogram, depending on the depth of the blockade. A waiting period of at least 10 minutes post-antagonism is advised before extubation, unless quantitative monitoring confirms a train-of-4 ratio greater than or equal to 0.9 sooner. Special considerations for non-steroidal agents. For benzylisoquinolinum agents like cisatracurium, only neostigmine can be used for antagonism. The guidelines suggest waiting at least 10 minutes after neostigmine administration for minimal blockade before extubation if quantitative monitoring is not available. The 2023 ASA Practice Guidelines provide a robust framework for the monitoring and antagonism of neuromuscular blockade, emphasizing patient safety and the reduction of residual paralysis. By adhering to these evidence-based recommendations, anesthesiologists can significantly improve patient outcomes. To learn more about anesthesiology, please visit us on our website at www.medspecialists.net and subscribe to our YouTube channel.